congenital thyrotoxicosis, because this is one condition which we need to be very much aware of, and this can have life-threatening consequences if it is not picked up at the right time. So what we need to understand is that this is a condition which is rare. We know that maternal Graves is present in 1 in 500, and out of these, you will have symptoms in probably around 2 to 5% they may develop hypothyroidism or hyperthyroidism. So overall, if you have 100 mothers, 2 to 5 will have babies who have thyroid dysfunction. Half of them roughly will have basically a hyperthyroidism and half will have a hypothyroidism, which may happen predominantly because of the anti-thyroid drug. So the overall prevalence of neonatal Graves' disease is approximately 1 in 25,000. So it's not an extremely common condition, but we need to be aware about that. From a physiology perspective, we know very clearly that the TSH cannot cross the placenta, while T3 and T4 can cross after inactivation to around 40%. So 40% of your thyroid hormones may cross. So if maternal levels are very high, baby's level will also be high. But the other very important thing to remember is that the TRAb antibody can readily cross. So the major cause of fetal thyrotoxicosis or Graves' disease in the fetus, is it because of the passage of the thyroid hormone, or is it because of intrinsic production by the baby, by the fetus? So what age of gestation do you expect this to happen? Beyond 15 weeks. So in the first trimester, the fetal thyroid is not going to produce anything. So this typically starts from around 15, 16 weeks, peaks. And if you remember the thyroid graph which I showed, the graph typically starts to increase by around 24, 28 weeks. So that is the peak time you will have. So second trimester, around 28 weeks is the time when you will have a lot of fetal thyrotoxicosis happening. So as a principle, this is going to be not driven by the excess thyroid. So if mother has even 50 nanomoles per liter, baby will only get 20 nanomoles per liter because only 40% is going to coming there. So this is not going to cause it. The cause is this TRAb antibody, which is there. The TRAb antibody has a half-life of approximately 2 weeks. So it may take around 8 weeks for it to be cleared from that regards. Methimazole can also freely pass the placenta. It has got a shorter half-life. So it may be there for up to 2 weeks. So basically what we are seeing is that if a mother is thyrotoxic, and who is on an anti-thyroid drug, will have a double effect on the baby. Anti-thyroid drug, which will first cause hypothyroidism, then you will have thyrotoxicosis because of the antibody. And that's why it's very important to have a delayed sample at day 14 for the baby to identify that from that regards. Remember that if you have prolonged deficiency of thyroid, you will have a transient scenario which is there in terms of a Graves' disease, which may happen in that regards. Long-term exposure to fetal thyroid excess, what will it do to the pituitary? So you may also have, in somebody who was exposed to very high thyroid hormone levels in the fetus, develop central hypothyroidism later on. So this picture may also happen. So you may have transient hypothyroidism, followed by transient hyperthyroidism, followed by congenital hypothyroidism. If, however, a baby has persistently high FT4 low TSH 6 months down the line, what are you thinking about? So it may not be an autoimmune, it may be a genetic cause of Graves' disease, which is there. The pathophysiology, as I said, is basically the trap which causes the placenta very readily. It is going to stimulate the production of thyroid, causing fetal Graves' disease. There could also be a TSH receptor mutation, which Dhwani was talking about, which may activate the thyroid gland. It's an autosomal dominant mutation. So both the mother and baby can also be affected in that regards, and you will have a high scenario. Another interesting cause of fetal thyrotoxicosis slash congenital thyrotoxicosis is McCune-Albright syndrome, in which the GNAS1 activity is more. And in this scenario, you will have many other manifestations like cutaneous manifestations, bony disorders, fibrous dysplasia, along with puberty. But thyrotoxicosis may be the first manifestation which is noticed right at birth in this scenario. So when should you think of thyrotoxicosis in the baby? If there is a pre and postnatal growth failure. So if you find the baby is not growing well, if there is tachycardia, fetal tachycardia. So when you're monitoring mother who has Graves' disease, you will check the heart rate of the baby. If it's high, or postnatally you have tremor, tachycardia or restlessness, and other features like stare. But definitely, if you have a history of maternal hyperthyroidism, you have to do a thyroid function in the baby right away. Prolonged Graves' disease may cause microcephaly. It may also cause cardiac failure causing hydrops, hepatosplenomegaly, and pulmonary hypertension. So neonatal Graves' disease, as I said, is because of the TSH receptor activation. Graves in pregnancy is around 1 in 500, and out of these, around 5% will develop some problem. Neonatal Graves as well as the other scenarios in that regards. Now, what are the risk factors? The most important causative factor I said is the TRAb antibody. So higher the TRAb level in the mother, 5 times the upper limit, would have a higher chance of developing the disease, and this is closer to the pregnancy. As close you are to the pregnancy, you will get this scenario. Fetal tachycardia and hydrops may develop. It may be severe and improve over 3 to 12 weeks. There is always a risk that your antibodies in the mother may persist. So despite getting them a radioactive iodine or a surgery, the baby may still develop these complications. So 5 years after radioactive iodine and 1 year after surgery, you need to be cautious about that. And this is something which is often missed, and the child may be missed in that regards. TSH receptor activating mutation basically is autosomal dominant disorder, which is a permanent cause, and the treatment there is largely surgery in that perspective. So if you have a mother who has thyroid dysfunction, particularly Graves' disease, you have to assess for both hypo and hyperfunction. If the maternal trap, particularly in the second trimester and 28 weeks is very high, you have to really bothered about. So you should do right at diagnosis and at 22 weeks, because that is the time when the fetal thyroid is now acting properly. So if you have high trap there, then the baby will develop Graves' disease from that regards. Do a fetal monitoring for heart rate and growth. Look for tachycardia, look for goiter, look for cardiomegaly. Fetal thyrotoxicosis is indicated by a heart rate which is more than 160 per minute, or there are features of a large goiter or a cardiac failure. The problem is that this can have a significant neurological impact. Too rapid maturation may happen, and if there is a cardiac failure, you may develop hydrops fetalis. The management is essentially treating the mother. You treat the mother with a higher dose, you control her thyroid. This may pass through the placenta, and this is also going to have an effect on the baby as well. And you can use digoxin if there is a cardiac failure in the baby. Postnatal assessment of thyroid function should be done right at birth and then at day 3 and 14 of life. Clinical features like heart rate and cardiac failure, hepatomegaly should be assessed for. TRAb antibodies may be done in cord blood if you want to have a high risk factor association in that regards. The acute management largely is in terms of usage of beta blocker, which is going to block the symptomatic symptoms as well as inhibit the monodeiodinase 1. Propranolol is the drug of choice, 1 to 2 milligram per kg per day. Anti-thyroid drugs, you can start with methimazole. I have used up to 1 milligram per kg per day because their levels are very high. You want to get these levels quickly. So I've used up to 1 and then try to bring it down gradually from that regards. And most cases, if they are frank Graves, they may require a short course of steroids as well. Hydrocortisone or prednisolone may be required. Extremely sick cases managed like a thyroid storm, give iodine. Remember, this is the most severe form of thyrotoxicosis. If you do not manage them well, they may actually die also because of cardiac failure. And the message is to identify them before they get into this problem in that scenario. So beta blocker, propranolol. Steroids, you can start prednisolone / hydrocortisone, and anti-thyroid drugs, methimazole, may be given. As the half-life is 2 weeks, most patients will go off by 2 to 3 months. If it's permanent, think of a TSH receptor activating mutation for which surgery has to be done. So Dr. Dhwani, 30-year-old lady with Graves' disease, 22 weeks of gestation, fetal heart rate is very high. What do you think is happening? So this is a fetal Graves. So this is something which is there. There is also cardiomegaly. So what will you do? So you will increase the dose in the mother and maybe think of digoxin also, which will also pass through there. So antithyroid drug should be increased in the mother, and that will be there. Day 4, infant of Graves' mother on methimazole has a FT4 which is low, TSH which is high. Why does he have hypothyroidism? And so what we did was that we observed Day 14, he developed hyperthyroidism because so now the anti-thyroid drug is gone and your TSH stimulating antibody is working basically, and then you will treat with methimazole and beta blocker. Day 12 child with irritability, not gaining weight, lost 600 grams of weight, has tachycardia, proptosis, everything is clear, FT4 is very, very high, TSH is very, very low. Mother had Graves, but radioactive iodine was given 2 years ago, so the doctor thought that they don't need to do monitoring. Do you agree with their observation? So how long after radioactive iodine you should get this monitoring done? Yeah, 5 years and 1 year after surgery. So this is something to remember. So half-life is there. So follow up at 3 months of treatment, FT4 is low, TSH is also normal. So what do you think has happened to this baby? Yeah, he was on methimazole. We started, we stopped. No, he is off treatment. FT4 is low, TSH is there. So, yes, so long-standing fetal thyrotoxicosis has actually suppressed his gland. Now, because he had too much antibody from the mother, which was there, that's why he became hyperthyroid. But once that antibody has gone, he's now gone into the central hypothyroidism. This is a very difficult situation. I would probably treat at this level because otherwise brain development will be affected. But this will be a transient treatment. This may improve or it may take a few months. It's something like you talk about reset axis. It's the reset axis in a different direction. Because of too much this thing, his pituitary is sleeping basically. That's what you can say. Normal development phase is normal. So plan here would be, this is basically because of the central hypothyroidism and you may consider treatment for some time, at least to maintain thyroid. Infant of Graves' mother, methimazole 10 milligram, day 14 FT4 is high, TSH is 0.01, methimazole was started, persistent disease at 6 months. What's happening here, Dhwani? So this is more of a genetic cause.